In the wake of the rising worldwide prevalence of obesity, we are seeing a growing burden from gestational diabetes mellitus with short and long-term health implications for both mother and baby. Gestational diabetes is glucose intolerance during pregnancy less than overt diabetes. So it is where the glucose in the mother's blood is slightly higher than normal, but less than the thresholds for overt diabetes. In gestational diabetes, this raised glucose is important for two main reasons. Firstly, gestational diabetes predicts future type 2 diabetes in the mother, providing an opportunity to prevent this progression. Secondly, the fetus is very sensitive to even mild perturbations of the mother's glucose and likely other fuels such as fatty acids. Gestational diabetes needs to be seen as a life course condition, needing a life course management approach. For the baby, there are also long-term risks, including future overweight and obesity and future type 2 diabetes. There is a saying in the gestational diabetes field that diabetes begets diabetes as part of a vicious intergenerational cycle. Those with early hyperglycemia, that is early gestational diabetes, are generally those at the highest risk of pregnancy complications.
The global prevalence of gestational diabetes varies between countries owing to inherent population prevalence, socio-cultural determinants of risk, and risk factors such as body mass index, family history of diabetes, previous history of gestational diabetes, and parity. The global prevalence of gestational diabetes was reported to be 14%. However, this prevalence estimate is a combination of early gestational diabetes diagnosed before 20 weeks of gestation and late gestational diabetes, which is diagnosed after 24 weeks of gestation. Very few studies delineate between early and late gestational diabetes. This should be factored into future research. Gestational diabetes is associated with adverse pregnancy and neonatal outcomes. Early GDM has shown higher risk for Caesarean delivery, induction of labor, insulin use, perinatal death, preeclampsia, preterm delivery, large for gestational age babies, shoulder dystocia, and congenital anomalies. Experience of fear, guilt, shame, discrimination, social isolation, avoidance of testing, and hesitance to share GDM management data are being reported in women with GDM. Further, early pregnancy depression increasing the risk of GDM diagnosis, and GDM diagnosis increasing the risk of postpartum depression. A bidirectional relationship is possible. Treating late GDM decreases postpartum depression, and treating early GDM improves the quality of life. Thus, treating GDM can improve mental health outcomes as well as physical pregnancy complications.
In women who have a normal BMI in pregnancy who go on to develop gestational diabetes, they have a decrease in insulin response, which is more manifest in early gestation and then persistent late gestation. In contrast, women who have a high BMI, complicating an increased risk of overweight or obesity, they have a robust insulin response in early gestation, which becomes less robust in late gestation, thereby resulting in hyperglycemia. Additionally, there's an increased risk of hypoglycemia in the immediate neonatal period, which places an increased risk on these infants of neurological dysfunction in the future.
We need to look at gestational diabetes from a life course approach, where action is needed beyond the antenatal period. Research suggests that possibly as many as 3 out of 10 women with type 2 diabetes have a history of gestational diabetes. Because of the elevated risk of diabetes, it is recommended that women with a history of gestational diabetes are regularly screened for type 2 diabetes. Identifying ways to reduce the impact of gestational diabetes and its associated adverse outcomes would be of significant societal benefit. Evidence has shown that timely detection and treatment can reduce the risk of maternal and neonatal complications during pregnancy and childbirth. However, to harvest the opportunities for prevention of future disease in mother and child, interventions beyond the immediate postpartum period are needed as well. In reality, there are many barriers to testing, management, and follow-up, and these barriers exist not only at the level of the individual woman, but also at the family level, the healthcare system level, and at the community and structural level. Aspects such as stigma, social support, and cultural practices also influence whether pregnant women are tested for gestational diabetes, and whether those who are diagnosed can follow the treatment and postpartum recommendations for breastfeeding, physical activity, and diet. Within healthcare systems, lack of feasible guidelines, resources, and effective follow-up and communication systems between healthcare providers and sectors are important barriers to detection, care, and follow-up. Due to limited resources and increasing rates of gestational diabetes, identifying strategies for diagnosis, treatment, and long-term follow-up that are effective and feasible in different settings are crucial. Such efforts may include employing a stratified model of care where identification and treatment of as many women with gestational diabetes as practicable are ensured, while intervening more intensively only among those at highest risk. Tailoring treatment and follow-up to the needs and wishes of the individual woman. Implementing new digital technologies and solutions. Coordinating and integrating postpartum diabetes screening and long-term follow-up with existing maternal and child services, such as vaccination programs and well-child visits.
As we've heard, gestational diabetes has consequences on the mother and baby, not only during pregnancy, but often well into the future. The numbers affected are growing across the world. Health service costs are a major burden, and the mental and physical toll upon the mothers and their babies is large. Gestational diabetes is heterogeneous, reflects a pre-existing predisposition to metabolic ill health, and the detection of gestational diabetes provides an opportunity to act during pregnancy to protect the offspring and mother, and afterwards to protect mother and baby for the rest of their lives. We have treatment that works, and we now know that many women and their babies would benefit from identifying and treating their gestational diabetes early in pregnancy. Other women still do develop their higher blood glucose later in the pregnancy, when the natural insulin resistance increases. We now need to develop new models of care to incorporate both those needing early and those needing later treatment. And this needs to be achieved in a way with the least physical and mental demands on the mother. We have entered an exciting new era with many questions needing answers on how to translate this new knowledge into clinical care. We need to identify and overcome the barriers to preventative care, better communicate the risks and benefits of any new approach with those affected, and ensure that no matter where you are, who you are, and what you can afford, you have access to such care, both for the mothers and for the benefit of the next and future generations. Thank you.